We're very pleased to welcome you to the Arthur Ludwig Lectureship in Humanism in Medicine. This lectureship is part of our Advancing Idealism in Medicine, or AIM initiative, which was founded in 2003. AIM includes a monthly humanism and wellness curriculum, research and resident well-being, and a grand round series that highlights inspirational role models in medicine. Today's award lectureship is named in memory of Dr. Arthur Ludwig. Dr. Ludwig arrived at Mount Sinai as an intern in 1943. After serving in the Navy during World War II, Dr. Ludwig completed his training in internal medicine, after which he pursued fellowships in both pathology and endocrinology. He remained affiliated with Mount Sinai throughout his entire life. Dr. Ludwig served as an attending in endocrinology clinic and as chief of the outpatient department diagnostic clinic. He was a true clinician investigator, engaging in research while maintaining a very active practice. Dr. Ludwig was regarded as a wonderful diagnostician and a strong patient advocate, which earned him the highest level of trust from his dedicated patients. And now to our speaker. This year's Ludwig speaker is Dr. Rita Charon, here for a discussion on narrative medicine. Dr. Charon is a professor of medicine, as well as founder and executive director of the program in narrative medicine at Columbia. She received her medical degree from Harvard in 1978 and a PhD in English literature from Columbia in 1999, concentrating on the works of Henry James. Her research focuses on the consequences of narrative medicine practice, reflective clinical practice, and healthcare team effectiveness. At Columbia, Dr. Charon directs the Foundations of Clinical Practice faculty seminar, the Narrative and Social Medicine Scholarly Projects concentration track, and the required narrative medicine curriculum for the medical school. Please join me in welcoming Dr. Charon.
Thank you. Thank you very much. Beautiful. Thank you. Thank you. I really feel honored to be given the chance to deliver the Arthur Ludwig lecture. Just think of the words you just heard here. AIM stands for the something of idealism in medicine. Advances. Even the positivist, we are doing it, advances. This is wonderful. Is this on? Yes. There we go. Oh, that's better. You had to open it. But in the same few minutes, we heard words. We heard the words of humanism, diagnostic acumen, and what amounts to the complete physician. So we're here to talk about the complete physician. What is it that is needed to be, as physicians, as clinicians, present, attentive, skilled, expertly skilled, affiliated with patients and their families so that we can accompany them through whatever comes. And I'm going to tell you a little bit about narrative medicine, but mostly I'm going to muse with you about how we think about our commitments. And I'm not going to talk only about our commitments to what are traditionally called the arts. And I'm going to challenge us in thinking that the arts are any different from the sciences. I think we're beyond that, and I'm going to tell you why. But narrative medicine, in the most brief way, is an effort and a commitment to bring into clinical practice those skills that are best taught in narrative studies, which is to say, what's a story? How does it work? What happens when one person tells another person that something happened? And it was to learn that I went from my clinic and emergency room work at Columbia over to the English department to say, can you teach a doctor something about how stories work? And they were happy to do that. I just didn't know that I wouldn't just take one course, but ended up with a PhD. I had no idea that would happen. And it was because the more I learned about very complex, foundational literary theory, narrative theory, phenomenology, philosophy of the subject, linguistics, the more I learned about that, I'm going to say, the better a doctor I became. And the more I was able to comprehend that which patients told me, and I knew because they told me that they told me things they would not have told other doctors. So that was the beginning of our trying to systematize and theorize and really make a field out of this hunch that the closer you are as a reader, the closer you are as a listener, and that these skills that one can learn from an English department or a creative writing department or a theater department, these skills, when brought into clinical settings, make an extraordinary difference, not only in what patients are able to register to us, but even how we ourselves undergo the day in, day out hearings and witnessings of pain and suffering and loss and death. We've described three movements of narrative medicine. The first one is attention. And this is a photo by Salgado, Sebastião Salgado, Brazilian photographer. But this is a Tuareg woman, northern Sahara. She is blind from trachoma and sandstorms. And I want you just to see the phenomenon. She is the only thing in the world. As we look at her, there is nothing but this woman staring forth. There is nothing. The background is black. Now she's looking at a photographer with photographic equipment, but imagine her looking at you, whether it's in a camp. She happens to be at a camp to get water in a drought. But the kind of attention we hope to achieve, and we teach our students to achieve, is there is nothing in the world except this person. All else is blacked out. That is the heightened attention of which we are capable as physicians. This is Salgado also. It's a plateau in Peru. The second movement is representation. Now, from the back of the room, there's somebody in the very back row. You're going to tell me, what do you see at the upper half of this photo? Okay, she said trees. So, at the upper half of the photo, there are these shadowy things. Trees, bushes, sometimes they look like clouds. Some of you might think they're clouds. Do you see? That kind of goes back and forth. So Salgado is a good enough artist that he's able to represent, capture the nuance, the vagueness, the ambiguity. Maybe they're clouds, maybe they're trees, maybe they're people, maybe they're bushes, maybe they're animals. He captures the fact that we don't know. This is a photograph of uncertainty. And so when we teach our students to write, or to paint, or to compose, or to draw, or to sculpt, when we teach them how to represent things, and when I say things, I mean situations in practice, we are teaching them not only to register documentable facts or information that is seen by anyone looking at the scene, but rather, what do I see? And I'm not going to fool myself into thinking I see more than, that I know more than I do. So this is a representation of ambiguity and of uncertainty and of doubt. And I hope you all would agree with me that there's not enough tolerance for ambiguity and uncertainty and doubt in the work we do. Nelson Goodman, the aesthetic theorist, says, when we perceive an object, we perceive a version or construal of it. Fair enough? Depending on where you're sitting, you're seeing, this mouse in a different way, just depending on where you're sitting. And then Goodman goes on to say, when we represent that version or construal, we do not copy it. We achieve it. Got it? We only see what we are able to represent. Otherwise, it just goes away. So this is why we make everybody write. Salgado, on a lake in the upper Amazon. They're polling. They're not rowing, they're polling. And the orb in the sky is the moon. So, what's the mood of this? Amy, what's the mood of this?
Mysterious?
Mysterious. All right. It could be ominous, it could be peaceful, it could be serene. By saying mysterious, you include all of those?
Yes.
Thank you. We see several boats. I'm interested in the fact that there are at least 2 guys in each boat, or 2 persons. There's nobody rowing or poling the boat by him or herself, right? So the third movement of narrative medicine is affiliation. And it's through these heightened acts of attention, through representation, that we get to the goal, which is affiliation, which is partnership, which is I will go where you need to go with you. All right? Megan didn't say anything about my name. She could have. You know your Greek mythology. You know that Charon is the ferryman who rows the boat across the river Styx to Hades. And when a patient first recognized my name, I was a young kid, I was a third-year medical student, I had a little red name tag, and I joined one of the ward teams, and the first day, a 26-year-old man with a hepatocellular carcinoma sees my name tag, he says, "So this is it." All right? And, you know, my father's Dr. Charon, my grandfather's Dr. Charon. It's actually Charon. It means wheelwright in French. You know, if you put the extra R in it that we lost coming across the St. Lawrence. So this young man died a couple of days later, big pulmonary hemorrhage. And I thought I had to change my name. It just seemed so brutal. It seemed so brutal that this young man had this terror as I stood by his bedside, stupid little third-year medical student. And I didn't. I ended up thinking that the name was something to live up to. That those shores of my river are the ones that I have to get to know the best, get to know all the perils, maybe the calm banks. So those 3, attention, representation, and affiliation, are the things that have guided us in developing what is now an international discipline in narrative medicine. You know, my colleagues and I wonder whether we're going to have a board and certifying, we don't know yet. But it is certainly a discipline that has its home, not just in stories are important, go get the patient's story, but rather this really deep foundation in the literary theory, the phenomenology, the language theories of what is it that complexly and transformatively happen when one person tells another person a story about something gravely consequential, okay? And nothing happens in medicine, nothing. Giving somebody the flu shot, nothing happens in medicine that's not consequential, that we know. Narrative medicine is a creative discipline. So we are in training either our graduate students, our medical nursing, social work, chaplaincy, physical therapy students, we teach them all, or working with faculty. And I have like my monthly seminars with the pediatricians, with the anesthesiologists, with the radiologists, with the social workers. Do you see? And what we're teaching them is how to read. We're teaching them how to write, not memoir, reflective writing. We're teaching them really creative writing, how to capture very complex states of affairs, situations, feelings in language. And again, we're also doing work now in visual arts and music, because our clinicians and trainees need ways to imagine and perceive what their patients go through, right? And it's through the creativity and the use of the imagination. It's the only way possible. because their patients are not themselves. And they have to get across that gulf of subjectivity toward an intersubjective contact, toward some form of authentic contact. But it has to go through some form of recognition, and the creative acts are the way to do this. They also, as a dividend, get to understand, represent, and then understand and deal with their own experience. So the creative arts are not elective in healthcare. It is, the more I do this work, the more I understand that it is our experiences of art that become, I'm going to say this out, our experiences of art free within our minds thoughts that we may not be aware of. And it is when listening to the late quartets of Shostakovich, or when standing in front of a Rothko Bars of Color, if you're lucky you go to Houston and sit in the Rothko Chapel. It's when you are in the presence of art or at theater that your mind's treasures are freed somehow. It's almost like a rising tide. Do you see what I mean? A rising tide that frees the scattered thoughts, and that we're able to have new thought. It's in the presence of art that we are able to have new thought. I've even written the sentence, I don't know if I can get away with this. Art makes thought possible. Can I get away with that? Lisa says yes. Do you know that Dr. Ludwig's family is here? His wife Laura is here, his daughter Amy, his daughter Lisa, and Andrew. I felt so privileged to hear from them last night about their father and husband, and to hear the kind of inspiration he must have been to you guys, those of you who worked with him, certainly even now in his tradition. And he knew this. Dr. Ludwig, I learned last night, is a pianist, a reader. I didn't hear much about visual art last night, but I have a feeling that there was an awareness there too. So we're in the presence, we are honoring a person who knew all this. Yes? Forgive me, this is a horrible painting. I mean, it's a brilliant painting, but it's terrifying. It's Max Beckmann, Bird's Hell. And it was painted in 1938, 39, as Beckmann realized what was coming with Nazism. And we have here a portrayal of utter terror. There is no corner of the canvas that is not filled with some form of injury, degradation, sadism. Do you see? Why do I show it to you? One of my medical students, Andrew Chen, and he gave me permission to say this, was on one of the narrative medicine seminars. They're required. All our first-year medical students have to do one. So he was at the Metropolitan Museum of Art, and he was told to pick a work and spend an hour with it. So this is the work he chose. And he stood in front of it. He didn't know Beckmann. He didn't know anything about Beckmann. But he stood in front of this painting. While he's standing in front of it, he comes to understand. He finds that he is understanding, while he's standing in front of it, the situation of a young suicidal woman that he's caring for in PI, in Psychiatric Institute. It comes to him, the terror that must surround this woman's life. It comes to him that there is no corner of her day, of her life, that is free from fear and free from thoughts of destruction. And before standing in front of Beckmann, he's young, you know, he's young and healthy. He couldn't grasp that a person in, you know, physically good health and not homeless and with people in her life that loved her would want to die. And Beckman taught him that. Do you get it? That's what I mean by art makes thought possible. This is the Ryoanji rock garden in Kyoto. I was able to sit with it for hours earlier this year. It was designed and built in 1499. 1499. It's 30 by 80 feet. And in the presence of it, one understands. In the presence of it, one understands the isolation of each individual and the ultimate connection among individuals. It's a realization that doesn't come except in the face of great art. Now, Megan went out of her way to say that Dr. Ludwig was a diagnostician. And his interests in the arts and reading and classical piano, he was also a jazz pianist, did not cancel out his commitment to the diagnostic sciences. And he was known as a physician who achieved great therapeutic relationships with patients, followed them very carefully through decades, and what he valued and prided himself on was his diagnosing of those rare cases that others didn't know what to do with. This reminds me of the Age of Wonder. He practiced an age of wonder. At the end of the 18th century, Royal Society of London brought together Wordsworth, Keats, Shelley, with Herschel, the astronomer, Davy, the chemist. They worked together. They understood that they were doing the same things, that the artists were not doing creativity and the scientists doing, I don't know what to call it, investigation, but rather that what William and Caroline Herschel did as they discovered Uranus, the planet, was the same thing that Shelley did as he wrote Prometheus Unbound. And in fact, their work spilled over into one another's. And Shelley and Wordsworth both include aspects of the heavens that they learned from Herschel in their works. So it was a time of history where there was no distinction between what is, so-called art and so-called science. They understood that they were doing the same thing. All right? We go till what, quarter after? 9:20. Okay. I think that we are entered into the second age of wonder. I think that today, not just in medicine and science, but I think that today we have the opportunity to have this second age of wonder, to know that the artist and the scientist are shared in these two major feats, F-E-A-T-S, of creativity and doubt. Now, I'm gonna show you part of what we call science, right? The left lobe, this is an operative note, liver transplant, some years ago. The left lobe of the liver was mobilized. The right lobe of the liver was now mobilized. The gallbladder was now mobilized with blunt and sharp dissection, removing it completely. The common duct was ligated with 2O silk ligatures. The liver was now ready for complete hepatectomy. The donor liver was now brought out and irrigated with 2 liters of albumin solution. The hepatectomy was now completed. I don't have to tell anyone in this audience what this means, but people who are not in medicine have to be told, well, this is where in this case it was a cadaver liver, this is where the liver of a dead person is put into the belly of a person whose liver has failed, right? The total anastomosis time for all venous structures was 30 minutes. The liver had good turgor. The abdomen was now irrigated with copious amounts of sterile saline and aspirated dry. The abdomen was closed in a one-layer fashion with 3O PDS simple running suture. The midline extension was closed with a figure of 8 of interrupted 2O proline suture. The patient tolerated the procedure well. Now, I want to ask you, what do you think it was like the first time somebody did this? Or how did someone even conceive that this was possible? I mean, this is an extraordinary, kind of ghoulish thing to do. Who figured out that one could take a good liver out of a dead man and put it into the abdominal cavity of a live man whose liver had failed, right? I tracked it down. It was 1908. It was Simon Flexner, brother of Abraham Flexner, who was the first director of the Rockefeller, who in the New York Times on New Year's Day, 1908, proclaims, I think someday it's going to be possible to take healthy organs and replace them for the diseased ones. But it wasn't, and somebody's going to Pittsburgh. It wasn't until Starzl and the Pittsburgh group in the really late 60s that the first successful ones. But how did they know to do this? What I want to have you ask is, can you imagine the doubts you'd have had as you started to try it? And can you imagine the creativity it took to decide that this was something that one could actually do? I'm always doing what I can't do yet in order to learn how to do it, right? And of course, this we know as the basis of experimentation. I'm going to skip a couple of these. What I'm trying to shed some light on is the nature of creativity, the creativity that Flexner had, that, hey, maybe this is going to be a possible thing to do, all right? Creativity means seeing things that not everyone sees, seeing as a visionary. It means being awake to surprise. It means having the capacity to expand the mind beyond the pedestrian or the expected. I mean, maybe it's just curiosity, inventiveness. But it also requires courage. It requires daring to not be beholden to authority or to rote or to convention or to approval, all of those things. It means having the freedom from the preconceived. To be creative requires that you approach what you are considering with humility, realizing you do not understand it, that there is no mastery. Instead, there is doubt. And the creativity gives you the chance to represent both the known and the unknown, and to use Amy's words, the mystery. Now, I've used the word doubt several times. You know what doubt is. It's that gray indeterminacy where you don't know, I'm sorry, that'll stop, where you don't know the up from the down. It's through this gray indeterminacy that creative people have to move as they're trying, searching this goal that they can't quite predict. I'm thinking, for example, of our novelist. I'm thinking of Henry James. He didn't know what was going to happen in Wings of the Dove or Portrait of the Lady. The only way he could find out was to tolerate his doubt and keep working. And it's not as if he solved his doubt. No. He came back from his excursion into it to give us a report of what it was like to be there. That's what art is. It gives us a report of what it was like to be in the doubt. It doesn't cancel the doubt. You spend any amount of time with a Rothko painting of bars of color, and you understand. It doesn't solve the doubt. It shows the doubt. So these artists are not solving puzzles. They're grasping, each with their own method, And here it's very useful to think of music. They're grasping with their own methods to see something that has yet to be seen. Yeah? So here are two sentences. They feel like the closest I get to writing equations. I'm going to read them. Creativity occurs when the creative person can tolerate doubt. And to tolerate doubt requires creativity. To tolerate doubt both requires and generates creativity. Right? That's who said that. It wasn't a scientist. It wasn't a experimentalist. It was one of our artists who exists really at that boundary, right? I mean, what did he do, right? He found ways to see the sky and the fields and the clouds in ways that no one else had ever seen it. I mean, you go to MoMA, stand in front of this, you understand that you will never see the sky and a cypress and the sun in the same way. So he was able to do what I can't do yet in order to learn how to do it, which is to say, he suffered through the doubt. Let me end now with another representation of my liver transplant. So this is written by a man who received a liver transplant. Richard McCann is a poet. He had Hep C, he had a liver transplant, and he's fine. And this is how he described getting a liver transplant. At night in bed, I often thought of the person who died. When I was quiet, I could feel myself quietly grieving for him, just as I was grieving for my own body, so deeply wounded and cut apart, though still alive. I'm sorry, I wanted to tell him. Sometimes I woke in the middle of the night, troubled, to realize that I had taken a piece of him inside me, as if I had eaten him to stay alive. Other nights, I thought of the donor with great tenderness, sometimes perceiving him as male, sometimes as female. These nights, I placed my hand over what seemed to be still her liver, not mine, and slowly massaged the right side of my body. A broken reliquary with a bit of flesh inside. It's okay, I whispered over and over, as if I were attempting to quiet a troubled spirit not my own. Now, what do you notice in these two slides? Any words stand out to you? Any ideas stand out to you? You know, this cannibal notion? Do we ever think that our transplant patients feel like they've cannibalized? Right? It's profound. I talked to the chief of surgery at Dartmouth. He used to be, he was a transplant surgeon. And he started telling me some of the things his patients would come and say. One couple came, the man had a liver transplant, and the wife said, I don't know, he's a different person. He's like acting really weird. I don't know what to do. I'm almost afraid of him. What? It must be the liver. You know? And then another patient of this same surgeon, and it told me something about this surgeon that the patients were able to say things. The man says, the man just learned that his liver had come from a woman. He didn't know that until a post-op visit. And the man got and he says, well, does that mean I can get pregnant? So we have no idea, what our patients go through. We have no idea. But I have to show you the word reliquary. Reliquary. that's these kind of gold, usually gem-encrusted containers in a Catholic church, into which is placed the piece of a body of a saint, like a tooth or hair, or like a piece of the body, literal body of a saint. That's a relic. And the people, the faithful, go pray to that relic for, grace, for assistance. So the piece of the body becomes a thing of great, great worship. And here Richard McCann figures his own body as simply a vessel for the remains of the saint.
But broken.
Well, yeah, thank you. And he's recovering now. He's recovering. His body, thank you, his body indeed is broken. It's been broken open. You might even say broken into. Do you see? But the notion that his task is now to contain and bring to others this saintly remains is extraordinary. So I just give you two sides, but you know what? I'm not going to call one science and one art. Do you see? The questing, I mean, thank God surgeons dictate their op notes. We wouldn't want them not to. Do you see? That these are Mobius strip related aspects of this heroic act of saving a life through this operation. One more story and then we'll stop. So now, and you see, we could have spent a lot of time doing a close reading of both of those accounts. What's the surgeon doing? Now the liver is placed, now the gallbladder is mobilized, now the sutures are placed. He's dictating this after the surgery, isn't he? So there's lots of very complex things to be seen by a good reader in both of these accounts. But this helps us to say, this is why healthcare is so extraordinary. This is the punchline. We get to do both, all right? At the same time that you have to know 3-O-proline from 2-O-proline, you have to know something about grieving and loss and the experience of being broken. I want us all, I hope we all can, and not just the students, understand this extraordinarily complex, delicate, powerful way of being with another that, as I've been saying, requires the imagination, requires an awareness of being the same and yet being different from one another, requires solitude, if only the solitude to write, solitude and engagement and enchantment and reparation, all of these things. I had a very elderly, well, he was in his mid-90s, a patient I was seeing for the first time. He was in the end stages of dementia. He could not speak. He had not spoken for months, if not years. He had a G-tube. He was in a wheelchair. He had an indwelling catheter. He could make some sounds. He could make some sounds that his family and home care worker interpreted as sounds of distress. He had been hospitalized at another hospital for a bout of pneumonia. And while and he was even in the ICU for a couple of days. And the dutiful ICU staff asked the son to sign a DNR form. And presumably they had been talked to before. Well, the son was livid. The son was livid. And in fact, they had gone to this hospital, EMS, and they took him to this hospital. So they approached the son to say, you know, if his heart should stop, you don't want us to, or I don't know how they did it, but if his heart should stop, we have to make decisions about whether to intubate him. The son was absolutely furious. I'm meeting him for the first time. He's in my office, he's banging don't you want to know what they told me, those doctors? They thought my father wasn't worth taking care of. He was livid, he was unconsolable. And there was his father, he all but snatched him out of they thought my father was not worth taking care of. And I couldn't contain his rage in the office. And there was a lot more I needed to know about this elderly man who was newly under my care. And I could have taken his side in this fracas. I could have tried to explain what DNR is. I could have made apologies for the hospital. But here he was in such elemental anger at how his father had been treated. So I didn't do any of those. I just asked him as quietly as I could, tell me stories about your father. And he did. And he told me about growing up in the Dominican Republic. His father had a big farm. His father taught this son everything about the farming. This was one of 8 sons. And he said to me very proudly, I was my father's favorite. And he told me about bringing his parents to New York once he and his wife and kids had arrived here, and they lived with them. And his sons knew their grandfather. And his rage, it quieted. It didn't go away, but it quieted. And I understood that during the hospitalization, he felt that he had had to betray his father. He was being asked to betray his father. And then a simple invitation to tell me about him gave him a way to honor him. So that's, you know, the kind of medicine that can bring us to different kinds of places with our patients. And you see how it requires both a deep understanding, in this case, of the end stages of dementia, and this, what I'm calling humble. I don't know anything. I am ignorant. Please help me to know. And this is just one example of these ways in which the imagination and the effort to perceive and the effort to represent can come right into the practice. So we just recently published it's really a textbook, and with the audacity of calling it The Principles and Practice of Narrative Medicine. And I chose one of the bars of color of Rothko for the cover. And the book really tries to articulate all of these ways of thinking about being with, about the cognitive, aesthetic, artistic, scientific aspects of this extraordinary work we do. So I thank you.
We have time for some questions, please.
How would you respond to the age-old question of not having enough time to
Oh,
patients?
I'm sorry. I usually start by saying I understand that's going to be the first question. I didn't do that today. I sort of didn't think I had to. We know how time is spent. And it's up to us to ask ourselves very clearly, what is the most important way for me to spend my time? I mean, I've been working in the clinic in PH for a long, long time. And we have all the meaningful use, or well, now they're not doing quite so much of that, but all of the eclipsis, all of the checklists. We're maybe even more sinister than you are. To open our problem list in eclipsis, the problem list is called the super bill. And the icon that you click in order to open it is a $. Okay? So that's a way of situating my answer, because we know that there has been a divergence between that which medicine is supposed to be doing and that which medicine is doing now. And so we have a lot of work to do to recover that which medicine needs to do within settings where we all have to work. So, what happens if you don't have enough time? Well, you come to understand very, very clearly what are the things that are required to do. All right? And we can all be very, very creative about who does what. And some of you use scribes. I've heard some of you talking about scribes in some parts of the hospital. That may be some kind of answer that you offload to someone else, some of the very tedious, time-consuming tasks. But it's up to us as physicians, as clinicians. I don't know if you're all physicians. I hope there are some nurses or physical therapists or PAs here. It's up to us to be very, very clear about the non-negotiables of time with our patients. And I don't think some of the check boxes and some of the repetitions about what was the date of your last mammogram and that's what I'm doing with the patient? No. Because we're there because the patient wants to say something to someone. If we're not the one to whom they say it, we've lost. Do you understand? And that's why we go through all the training, to become trustworthy as listeners. So all of us, we're much more powerful than we think we are. You know, and so the shareholders of Prudential and Aetna and Cigna are telling us how much time to have in the office with patients? No. So we have to get very savvy. We have to get very, very savvy down into the who does the lobbying and what Congress people are voting. And of course, since November, it's all surreal. But that's the answer to the time question. It's not, oh, hurry up. It's not that. It's you tell me I have 12 minutes, says who. And we have to get very, very smart and aggressive and powerful in responding. And we have much more power than we think. Do you think so? Yeah, I got a reluctant nod from him.
Along those lines, what do you think about electronic medical records and templated medicine? Which I hear a lot, from different generations of people who are using electronic medical records. You've lost.
Yeah. So we have to make sure not to rule out the unthought known. We have to make sure that we're not being asked to make choices just among the simple things. I'm thinking of Dr. Ludwig. He wanted the rare cases that nobody knew what it was because he wanted to think about it and not, on a Chinese menu. A former student of mine, appalled, wrote to me from Boston after he started his internship. Do you know, he says, do you know they don't even let us write sentences? We have to choose phrases. The patient was in his usual state of health until. He says, they don't let us write. What am I going to do? This was one of my writers. All right? Because he knew that it is only in the act of composing, it is in the act of representing that you come to know what you know. So I worry most about the templates because we're not going to be writing. And it's in the writing. You know this, right? It's as you write the note that you understand what you think. Have you had that experience? You get to the bottom of the note. Oh, I guess I'm thinking about PE. Look at me. I'm ordering a CTN. I'm serious. I'm serious. It happens all the time. And then, of course, if you're not a writer, you don't get to do the kind of the intensive care narrative work. If I'm not sure what's going on with a patient, you know, I will write down what I recall. I mean, like 2 paragraphs, like no big deal. Like write down, this is what I remember. And then I will mail that to the patient or email it or give it to her the next time I see her. I say, this is what I remember. You know, did I get it right? And extraordinary things happen. At the beginning, I was thrown. By now, I'm used to it. The patient will read this, and she'll say, well, you got my kids' names wrong, you know, and it wasn't 2013, it was 2000. But then she'll say, you know, we left something out. And that's when I hear about the stillborn, or the first husband, or the fire, you know. I mean, the fire happened 20 years ago, but the fire, do you see? And I would not have learned those things for years. But a simple act, a simple narrative act. Here, I'm trying to understand what happened. It was confusing to me. Is this kind of, help me get it right? And then it cranks the relationship up. Do you see? And there's many, many, many variants of that. And I don't want my students and my physicians to lose the power of representation. And you got to admit, more people are going to write than are going to compose a string quartet. So I concentrate on the writers. That's what I don't want to lose. So if the templates make it less likely that doctors will even in their minds connect writing with clinical work, then that's a hazard. But it's also a hazard diagnostically, you know that. What are we going to do about that? Who's in charge of the templates? Any of you on the EMR committees?
I'm not going to call you out.
Yeah, don't. Just leave it alone.
I mean, we got to even do the boring work. We all should be on the EMR committee, you know?
One more question, please.
More of a question, but I've actually met two of the people that teach in your program unexpectedly.
Oh,
I just
nice.
happened to, and I attended a short conference workshop with Dr. Dasgupta.
Oh, good, yes.
At any rate, I've been practicing for a long time. I've often thought about the stories that do occur, not only my patient's stories, but the stories between us.
Yes.
And I'm curious about, one, if there's a body of literature about that, and two, I'm not a writer. I've often wanted to get this down, and is there a place to go? Yeah.
See,
Yeah.
this is the lie.
Yeah.
Yeah. I heard last night from Amy about somebody who thought she wasn't a writer. You said she wasn't a writer, and then you said, well, make a list.
Oh, that was, yeah. When I was teaching
Tell her that story. Go ahead, stand up, tell her that story.
Sorry, I didn't realize. I used to teach playwriting as a teaching artist in Chicago. And one of the assignments to the students was, can you write a description of a person in your life, like how they might become a character? And the kids said, oh, I can't write, I don't know anything. I said, well, just make a list. What do you know about them? What color hair do they have? What kind of music do they listen to? What's their favorite food? And just by making a list, because that's not writing, it takes the fear out of it. Because everyone can sort of list a bunch of facts, but then you start seeing all this, and then they go, oh, now I know what story I would tell about them.
See?
So it's a trick of the brain to get out of the fear of the formal.
So it's something that we all do. So, I mean, I can tell you about ways in the city. I mean, there's loads of writing workshops, online things. You know, if you here don't have places to go to write, well, you need them. You know, you're doing some work with the students. You got to do some work with faculty. Come on, give me a break. They're the ones who have to model it. And it is such pleasure. I mean, we get together twice a month, faculty. We mostly read. We read fiction, but we also write. So hustle for it here. I'll find you a writing teacher if you can't find one. But do it here.
So before we end, I really wanted to thank Dr. Ludwig's family again for supporting the department so much and coming every year. It's really great to have you come and to spend time with us all the time and to remember Dr. Ludwig and his time here. So, and then I'd like to thank Dr. Charon, obviously, for a very thoughtful presentation, and I think we all can take back to our day today. So